Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. Welcome to set 1 of the part 1 questions. Remember, before you watch these video answers, you need to download the PDF of the questions, which you can find by clicking on the link just below the video viewer. And you need to be sure to work through the questions before you watch these answers, and look up any of those answers that you couldn't come up with on your own. That's going to help you become familiar with this material. So, if you haven't answered these questions on your own, pause the video and do that. And then come back after you've answered the questions. Let's get going. First question here, what is the first line treatment for a patient with erectile dysfunction? Well, we got to think about the phosphodiesterase inhibitors. So this includes things like sildenafil, vardenafil, and tadalafil. And then the other treatment that you would want to consider for first line would be if the patient has hypogonadism causing that erectile dysfunction. So you'd want to start that patient on something like a testosterone replacement. Next question, what is the difference between urge, stress, and overflow incontinence? Well, the definition for urinary incontinence is simple. It's an involuntary loss of urinary control, generally in socially inappropriate situations. Now, what about the different kinds of incontinence? So we have the urge urinary incontinence, stress urinary incontinence, and overflow urinary incontinence. So how do these differ? Well, in urge urinary incontinence, you have urinary incontinence due to uninhibited bladder contraction. So these are the gotta go right now or I won't make it to the restroom in time situations. The urge comes on too quickly. Now, the diagnosis is often clinical, and certainly you want to do a urinalysis to rule out urinary tract infection. Now, the more elaborate workup of imaging is often not necessary, but treatment of urge urinary incontinence is going to consist mainly of the anticholinergic medications. Now, stress urinary incontinence is characterized by the involuntary leakage of urine during any maneuver that causes an increase in abdominal pressure. So classically, these patients will present complaining of urinary leakage when they cough or when they sneeze, exercise, or lifting something heavy. Now, this is due to decreased anatomic support and function of the urinary sphincter. Now, one way to assess the severity of the leakage is to ask them if they wear a pad and how many pads they might have to wear in any particular day. Now, the risk factors for stress urinary incontinence include obesity, multiparity, and being female. Now, it is less common for men to have stress urinary incontinence unless they've had a history of urethral or maybe prostate surgery. And then finally, overflow incontinence. This comes from the overflow of urine from an overly distended full bladder due to incomplete bladder emptying. Now, the symptoms are that of constant urinary dribbling, feeling of incomplete bladder emptying, and that bladder fullness. Now, on physical exam, you can often even palpate a distended bladder. Now, common causes of overflow incontinence include bladder outlet obstruction, often seen in men from benign prostatic hyperplasia, or BPH. Or from urethral strictures. Now, in men or women, you can get an atonic neurogenic bladder where there's no obstruction, but the bladder muscle has just lost its capacity to contract, and therefore they cannot empty their bladder. Now, this results in overflow incontinence as well. And also, this can arise from a detrusor impairment as well. Next question. A patient with Crohn's disease fails traditional therapy, so things like 5-ASA, steroids, immunosuppressants. What other drugs are used to treat Crohn's disease that target that TNF-alpha? So that's going to be infliximab, adalimumab, and cerulizumab. Next question. With what physical exam finding must you presume a scaphoid fracture despite a normal initial X-ray? What might result in a proximal fracture of the scaphoid if left untreated? So anytime you have tenderness in the anatomical snuff box, you have to presume that there's a scaphoid fracture, even if the X-ray is normal or negative, because sometimes those fractures don't show up very well on X-rays right away. And then what might result in a proximal fracture of the scaphoid if left untreated? So you can actually get avascular necrosis in the proximal fragment because blood is supplied from distal to proximal in that area. Next, what is a cholesteatoma and how does it present? So this is actually an overgrowth of desquamated keratin debris within the middle ear space. So this is up against the inside of the tympanic membrane. It's important because it can eventually erode the ossicles in the middle ear and the external auditory canal, and it can lead to some hearing loss. So for that presentation, these are commonly associated with chronic middle ear infections, and on physical exam, you'll see sort of this grayish white pearly lesion behind the TM. That's important, it's behind the TM, and it can also present with things like conductive hearing loss or even vertigo. Next question. During what week of fetal development will the fetus reach the following landmarks? So first we have implantation. That's going to occur within 1 week. Organogenesis is weeks somewhere between 3 and 8. Heart begins to beat around week 4. You can distinguish male or female genitalia at about week 10. Gastrulation is when that embryo goes from a 1-layer blastula to a 3-layer gastrula. That's going to be occurring somewhere in the first 3 weeks. Formation of primitive streak and neural plate is within 3 weeks and is complete by that 4th week. Next question. What is the initial medical treatment for the arrhythmia known as Torsades de Pointes? So torsades is a ventricular arrhythmia that is characterized by a sinusoidal pattern of wide QRS complexes. So it looks like the twisting of a ribbon, so that's where it gets the name, the twisting of the points. Now, to answer the question, the treatment for torsades is to push magnesium sulfate through the IV. Normally, mag sulfate is administered over several hours, but in a life-threatening arrhythmia such as torsades, you're going to dose that very rapidly. Next question. What are the adverse reactions of exogenous testosterone in males? So, if you're giving testosterone to someone, what can happen? Well, if you give it to children, you can potentially get premature puberty. Also in children, you can get premature closure of the epiphyseal plate, so those are the growth plates, so you get growth restriction. You can get erythrocytosis. You can get worsening of sleep apnea, and this is more in adults, obviously. Suppression of spermatogenesis, and then you can have a worsening of your cholesterol by seeing an increase in LDL and a decrease of HDL. Next. Which diuretics are most appropriate for patients with hyperaldosteronism, and what are their important side effects? So the most appropriate diuretics are the potassium-sparing diuretics like spironolactone, triamterene, amiloride, and eplerenone. Spironolactone and eplerenone act as competitive aldosterone antagonists in the cortical collecting tubule. Triamterene and amiloride block sodium transport channels in the cortical collecting tubule, which results in a decrease in the sodium-potassium exchange. Because all of these medications help retain potassium, hyperkalemia is a potential adverse reaction. And then also spironolactone has an anti-androgen effect that can result in gynecomastia in males and menstrual irregularities in females. Next, what structures give rise to the blood-brain barrier? So the blood-brain barrier is formed by 3 structures. So you get tight junctions between non-fenestrated capillary endothelial cells. You also have it within the basement membrane and then the astrocyte foot processes. That's it for set number 1. I hope you learned something. I'll see you next time.